95%.
Oh.
That is the statistic that completely stopped me in my tracks when preparing for today.
Yeah, it really is a staggering number.
I mean, 95% of patients in a clinical study on chronic vulval pain reported a severe decrease in their libido. Imagine your own body's natural defense mechanisms effectively destroying your sex life.
And worse, making you terrified of even a simple hug from your partner.
Exactly.
It speaks to this level of silent suffering that we rarely bring out into the open. We tend to view sexual dysfunction as a secondary, like a almost minor side effect of medical conditions. But here, it is the primary casualty.
Which is exactly why we are pulling it out of the shadows today.
Hmm.
We are addressing you directly, whether you are a patient navigating this yourself, a supportive partner trying to piece together what's happening, or just an insanely curious learner.
Because the mission today is vital.
It is deeply personal. We are asking, how does vulval lichen sclerosus, or LS, physically and psychologically dismantle sexual intimacy? And more importantly, how do you reclaim it?
It is such a complex landscape because we aren't just dealing with a localized skin issue here.
No, it's not just dermatology.
Exactly. It is this massive collision of dermatology, neurology, and psychology. The disease alters the physical architecture, which rewires the nervous system, which then completely rewrites the psychological experience of intimacy.
And to get to the bottom of this, we have pulled together a stack of highly credible sources for our deep dive today.
Really excellent sources.
Yeah, we are looking at medical texts like the Handbook of Gynecology, patient support guides from the Lichen Sclerosis Support Network and the LS Guide, plus clinical insights from the Vulval Pain Society and hospital pamphlets from Oxford University Hospitals.
And by synthesizing these specific texts, we can move past just, admiring the problem.
Exactly.
These sources provide actionable, evidence-based strategies for actually breaking the cycle of pain.
Okay, let's unpack this. For anyone listening who follows this topic, you already know the baseline of LS.
Right, the immune-mediated nature of it.
Yeah, you know about the chronic inflammation, the intense itching, and the pale skin changes.
Sure.
But I want to look specifically at the cellular mechanics of why this ruins intimacy.
Yeah.
Because the sources describe the altered skin as having a cigarette paper or parchment texture.
Yes, that's the clinical description.
And that isn't just a color change. That is a fundamental loss of elasticity, right?
What's fascinating here is how the pathology directly dictates the mechanical failure during intercourse.
Go on.
Well, when the immune system attacks the localized tissue, and it primarily targets the labia minora, the clitoral hood, and perineum, it destroys the skin's normal collagen structure.
Oh, wow.
So the skin becomes severely thinned out, like that fragile cigarette paper you mentioned. So when we talk about penetrative sex, an act that absolutely requires tissue to stretch, yield, and accommodate, the altered LS skin simply cannot perform that function.
Because it can't stretch, so it just tears. I mean, if the tissue is essentially wet cigarette paper, any friction is going to cause a breach.
Exactly. It results in microtears and tiny fissures across the vestibule and perineum.
Which has to be incredibly painful.
It is. You have immediate pain, bleeding, and an intense burning sensation.
Right.
And because the entrance to the vagina is packed with a really high density of nerve endings, the pain of those fissures is exquisite. An act of connection instantly becomes an act of physical trauma.
And reading through the texts, it is not just the texture tearing, is it? The actual architecture of the anatomy gets effectively erased through fusing and resorption.
Yes, those are the two primary structural changes.
And the distinction between those two processes is brutal. I mean, fusing is when two raw, inflamed surfaces literally scar together, like the clitoral hood sealing completely over the gland.
Right, they adhere to one another.
But resorption is even more insidious.
It really is. Resorption is when a distinct anatomical structure, like the labia minora, is essentially absorbed into the surrounding tissue.
Just absorb.
Yeah, the architecture goes completely flush. You lose the physical boundaries that normally guide and protect the vaginal entrance and clitoris during intimacy.
Okay, so if the skin has lost its architecture and the entrance is literally tearing during sex, the body isn't just going to sit there and ignore that trauma.
Definitely not.
I imagine it starts bracing for impact, which brings us to the pelvic floor. It feels like the body throws up a barricade.
That is a perfect way to look at it. The pelvic floor muscles form a supportive hammock across the bottom of the pelvis.
Right.
They attach from the pubic bone in the front to the base of the spine in the back. And because the vulval skin lies directly over these muscles, they are intimately connected.
So they react to each other.
Exactly. When you experience the acute trauma of tearing during sex, or even just the chronic maddening itch of a flare-up, those pelvic floor muscles involuntarily clamp down to protect the sore area.
Like a drawbridge where the gears are jammed by inflammation and fear. It just locks in the upright position.
A locked drawbridge is a highly accurate analogy. Clinically, we call this pelvic floor myalgia.
Myalgia.
Yeah. And when it becomes a chronic anticipatory squeezing around the lower vagina, it's known as vaginismus. It makes the vaginal entrance physically tighter and smaller.
So now you are dealing with two physical barriers. You have fragile skin that tears and a muscular wall actively fighting penetration,
Exactly.
which feeds directly into a psychological ripple effect that the sources call the cycle of pain.
Right. It's a very recognized cycle.
And this cycle completely dismantles arousal. Break down the biology of that for me, because it is not just a mental block. Fear actually changes the blood flow, doesn't it?
It does. It's rooted entirely in the nervous system. The cycle starts with vulval pain, which creates a very rational fear of future pain.
Which makes perfect sense.
Right. And when you are afraid, your sympathetic nervous system, so the fight or flight response, takes over.
Because your brain perceives penetration as a literal physical threat.
Yes. And the fight or flight response is the biological opposite of the parasympathetic nervous system, which governs rest and digest, and crucially, sexual arousal.
Oh, I see.
When a person is aroused, the parasympathetic system directs blood flow to the genitals. That causes the tissues to engorge, the vagina naturally expands, and lubrication occurs.
But anxiety acts as a hard stop to all of that.
Exactly. It diverts blood away from the area. So when a patient attempts sex out of obligation while anxious, there is zero natural expansion or lubrication.
Which causes massive friction.
Yes, which causes more tearing, reinforcing the fear.
It is a devastating self-perpetuating loop, and it leads right back to that 95% statistic we mentioned at the top.
Sadly, yes.
But there was a specific detail in the Oxford University Hospital's pamphlet that hit me even harder than the statistics.
Was it the fear of the green light?
Yes, exactly. The withdrawal from all non-sexual affection.
It's incredibly common.
The pamphlet describes how people with LS often get to a point where they won't even cuddle on the sofa. They won't hold hands or give their partner a lingering kiss.
Right.
And it's not because holding hands hurts, but out of sheer terror that their partner will interpret that physical warmth as a green light for sex.
Which is a profound tragedy of miscommunication.
Yeah.
The patient is isolating themselves just to survive physical pain, but the partner, who lacks that internal context, often interprets the sudden physical withdrawal as a loss of love or attraction.
So the emotional intimacy decays right alongside the physical capability.
Unfortunately, yes.
So what does this all mean for the patient listening right now? I mean, is the libido just permanently broken? Has the neurological hardware been permanently damaged by this cycle?
No, the hardware is absolutely not broken. And this is a vital distinction in psychosexual literature.
Okay.
We really have to separate spontaneous desire from responsive desire. Society tells us desire should be spontaneous, like a sudden craving out of nowhere.
Right, like in the movies.
Exactly. But for many, especially those in long-term relationships, desire is responsive. It builds in response to pleasurable touch and emotional connection.
But if touch only equals pain, that response mechanism is constantly short-circuiting.
Precisely. The capacity for desire is still entirely intact. It is simply buried under layers of severe anxiety and a highly sensitized nervous system.
So it's still there.
Yes, if we can remove the pain and remove the expectation of trauma, that responsive desire can flourish again.
Okay, so how do we actually get out of this loop? Let's look at the medical toolkit to physically prepare the body to reclaim that space.
Well, the baseline, of course, is optimizing the use of super potent topical corticosteroids.
Like clobetasol.
Yes, to halt the inflammation. But the LS guide was very specific about the application routine. It is not just about what you use, but how you use it.
Because the timing is critical, right?
Exactly. You apply the steroid gently to the affected areas, but then you must wait a minimum of 20 minutes before applying any emollient moisturizer.
Because if you don't wait, you ruin the efficacy. You basically dilute the steroid.
Exactly. The 20-minute window allows the skin to fully absorb the active medication.
Makes sense.
If you slather an emollient on immediately after, you risk wiping the steroid off the inflamed areas and spreading a super potent medication onto healthy tissue that doesn't need it.
Which can cause its own set of skin issues.
Precisely.
And those emollients should be replacing all harsh soaps and shower gels anyway to protect the skin barrier.
Absolutely.
Okay, but steroids take months to reverse tissue changes. What about immediate pain relief? Because here's where it gets really interesting.
Okay.
As I was reading through the stack, I found what looked like a massive glaring contradiction about pain management right before sex.
Ah, the lidocaine issue.
Yes, the Oxford University Hospital's leaflet and the LS Guide both issue strict warnings against using numbing creams, like lidocaine, before penetrative sex.
They do.
They argue that if you numb the area, you won't feel your skin tearing and you will cause severe long-term tissue damage.
And that is a very real warning. You do not want to push through a structural tear.
But then I flip over to the Vulval Pain Society and the Handbook of Gynecology, and they actively recommend using 4% or 5% lidocaine ointment minutes before sex as a way to cure entry pain.
Right.
They make it sound like a miracle fix.
Hmm.
So how do we reconcile two highly credible medical sources giving completely opposite advice?
Well, if we connect this to the bigger picture, it all comes down to differentiating between two completely distinct types of pain.
Okay.
The warning against lidocaine is aimed at patients experiencing active, severe LS skin changes, where the primary issue is fragile skin that is structurally tearing.
Right, because if your skin is actively splitting, masking that alarm bell is dangerous.
Exactly. You'll cause a major injury and set your healing back by months.
But what about the other side of the contradiction, the recommendation for lidocaine?
That recommendation is aimed at a specific secondary pain condition that often develops alongside chronic vulval issues.
What's it called?
It is called localized provoked vulvodynia or vestibulodynia.
Vestibulodynia.
Yeah. Over time, chronic inflammation causes the nerve endings at the vaginal entrance to hyperproliferate. They multiply and become incredibly hypersensitive.
So this is pure nerve pain.
Yes. Patients experience allodynia, meaning a normally painless touch, like a cotton swab or just a finger, registers to the brain as burning agony.
Oh, wow. So the lidocaine targets the hyperactive nerves, not the skin structure.
Correct. A 4 or 5% lidocaine ointment applied to the vestibule for just a few minutes before intimacy acts directly on those hyperproliferated nerves.
Interesting.
It extinguishes that initial spike of burning entry pain. But crucially, it does not eliminate deep pressure or normal touch sensation.
So you can still feel what's happening.
Yeah, and by preventing that agonizing initial burn, it stops the pelvic floor muscles from violently spasming. The drawbridge stays down.
Wait, if I'm a patient sitting at home reading this, how on earth am I supposed to know if my pain is nerve pain or tearing pain?
Well, you can't.
Because guessing wrong and pushing through a structural tear because I'm numb sounds incredibly dangerous.
It is. You absolutely cannot guess at home, and that is the most important takeaway for you listening today. This requires a clinician.
They have to test for it.
Exactly. A knowledgeable doctor will perform a very specific exam, often called the Q-tip test.
Oh, the Q-tip test. I saw that.
Yeah, they gently apply pressure to map out exactly where the pain is originating and visually confirm if the skin is intact or if it is fissuring.
Got it.
So lidocaine is a powerful tool for nerve-based entry pain and muscle spasms, but it absolutely requires professional guidance to ensure you aren't masking a structural tear.
That clears it up immensely.
Yeah.
It isn't a contradiction. It's just a highly specific application based on proper diagnosis.
Exactly.
But even with steroids and doctors, medical treatments take time, right? Pelvic floor physical therapy to unjam that drawbridge takes weeks or months.
It is a slow process.
So how can couples maintain intimacy in the meantime? Because if they just stop touching each other, the emotional distance sets in, and we end up right back at the fear of the green light.
This requires a fundamental shift in how we culturally define intimacy.
Okay.
The texts emphasize that our society views penis and vagina penetration as the only real sex. Everything else is relegated to just foreplay.
Right.
For LS patients, that definition is not only unhelpful, it is actively harmful. Intimacy must become a menu.
I love that. And if penetrative sex is off the menu today because of a flare-up or tight muscles, you don't throw away the whole menu.
No.
You just order something else.
Exactly. The sources heavily promote a psychosexual therapy technique called sensate focus.
I read about this, but I really want to know what it actually looks like in practice. Because to someone in pain, psychosexual therapy sounds like a lot of work.
It's actually about removing work and removing expectations entirely.
How so?
Sensate focus is a structured practice of non-goal-oriented touching. It takes orgasm and penetration completely off the table. In the early phases, partners take turns touching each other's bodies, strictly avoiding the genital areas. The focus is purely on the physical sensation, like noticing temperature, texture, and pressure.
So it's essentially mindfulness, but with a partner.
Yes, exactly. And the biological goal is to rewire the brain.
To stop the fear response.
Right. By repeatedly experiencing touch that does not lead to pain, the nervous system stops associating intimacy with threat. The parasympathetic system can finally turn back on.
Oh, that makes so much sense.
And as couples progress to touching the genital areas later on, they already have a foundation of safety. And with LS, the type of touch matters immensely.
Right, because rubbing creates friction.
And friction is the enemy of delicate skin. But gentle, firm pressure or cupping might feel deeply safe and arousing instead.
You are literally learning a completely new physical language together.
You really are.
But let's shift gears for a second, because we've been talking a lot about long-term couples.
Yeah.
What if you aren't in a relationship? The mental burden of dating with this condition, of having to explain this complex medical landscape to a brand new partner, seems completely overwhelming. How do you even begin to bring it up?
The sources recognize this immense hurdle, and they actually provide tangible, rehearsed scripts for singles.
Having a prepared script must shift the dynamic a lot.
It does. You are no longer scrambling to explain a so-called broken body in the heat of the moment. You are calmly setting boundaries up front.
The text gave a really great example. It was something along the lines of, I have a skin condition called LS. It means we need to take sexual touch a bit slowly. I would like you to let me know what feels good to you, and I will let you know what is good for me.
It is brilliant in its simplicity.
It really is.
It names the condition neutrally, removes the panic, and immediately frames the interaction as a mutual exploration rather than, like, a medical accommodation.
It gives the patient the control back.
Yes, it sets the pace, which instantly lowers the anxiety.
But I have to ask the hard question, the one that I think a lot of patients are terrified of.
Okay.
What happens when the disease was caught too late? We talked about fusing earlier. What if the anatomy is already lost and the clitoris is completely buried under scar tissue? Are there surgical options to rebuild that architecture?
There are surgical interventions, specifically the surgical division of labial adhesions or clitoral unfusing.
Okay.
But they are approached with extreme caution by surgeons. Most specialists will avoid the operating room unless there is a severe functional issue,
Like what?
like the fusion trapping urine, causing recurrent infections, or completely blocking the vaginal entrance.
Why the intense hesitation to operate? I mean, if the tissue is scarred over, shouldn't cutting it free be the obvious fix?
You would think so, but it's because of a process called the Koebner phenomenon.
The Koebner phenomenon.
Yes. In patients with active autoimmune or inflammatory skin conditions, physical trauma to the skin, like a surgical incision, triggers a massive immune response at the site of the injury.
Wait, so the trauma of the surgery itself causes the body to attack that exact spot even harder?
Yes. The surgery can trigger a severe flare-up of the LS, which can cause the raw edges to scar together again, potentially leaving the fusing even worse than before the surgery.
Oh, wow. That is a terrifying catch-22. You need surgery to fix the scar, but the surgery causes more scarring.
It is very challenging.
How do doctors possibly get around the Koebner phenomenon?
When surgery is deemed absolutely necessary and is performed by a true vulval specialist, they mitigate the Koebner risk with aggressive, immediate post-operative interventions.
So they don't just cut and send you home.
Definitely not. They might use intense topical steroid applications immediately following the procedure to suppress that immune response.
Okay.
They also frequently prescribe estrogen cream to help plump and thicken the healing tissue.
And the sources mentioned a material called Surgicel. How does that factor into stopping the refusing?
Surgicel is fascinating. It is an oxidized, regenerated cellulose material.
What does that mean?
Think of it as a biodegradable medical scaffolding. The surgeon places it between the newly separated raw tissues. It physically blocks the labia or the clitoral hood from touching the adjacent skin while it heals.
So it acts as a physical barrier until the skin has healed enough not to stick to itself.
Exactly. It provides a matrix for healing and physically prevents the anatomical structures from fusing back together during the most vulnerable recovery window.
That is amazing.
And when managed with that level of multidisciplinary care, surgery can successfully restore both the anatomy and sexual function.
That is incredibly hopeful. It proves that even in severe cases, the door is not permanently closed.
No, it isn't.
So bringing this massive puzzle together for you, the listener,
Yeah.
we have journeyed through a really intense landscape today during this deep dive.
We covered a lot of ground.
We've seen how vulval LS creates intense physical roadblocks,
Hmm.
the thinning of the skin, the architectural fusing, and the involuntary drawbridge spasms of the pelvic floor.
Mm.
And we've seen how those physical roadblocks naturally trigger a devastating psychological cycle, shutting down arousal and creating a fear of the green light.
This raises an important question for anyone managing this condition.
Which is,
How do you treat a disease that is so deeply intertwined with both our physical biology and our emotional nervous system?
the answer is that you have to attack it on all fronts simultaneously.
Absolutely.
You optimize your steroid routine to halt the cellular inflammation. You utilize pelvic floor physical therapy to unjam those muscles. You rely on precise medical guidance for tools like lidocaine.
Yes.
And crucially, you use psychosexual therapy and radically open communication to heal the anxiety and rewire the brain for pleasure.
Because by redefining intimacy as a menu, rather than just a single penetrative event, a fulfilling, vibrant sex life isn't just a possibility, it's entirely achievable.
It requires immense patience, though.
It requires unlearning what we have been culturally conditioned to believe sex is quote-unquote supposed to look like, and replacing it with what actually feels good for your specific body.
And that leaves me with a final thought for you to mull over. Our society places a massive, heavy burden on spontaneous desire and penetrative sex as the absolute gold standard of romance.
It really does.
If you aren't operating on those default settings, society subtly implies your relationship is failing. But think about what a condition like lichen sclerosus actually demands of a couple.
It forces you to hit the brakes.
Yes, it enforces profound, honest communication about boundaries. It requires you to explore sensate focus and redefine pleasure entirely on your own terms, mapping the body with intention rather than blind expectation.
Right.
What if the radical communication, the deep empathy, and the slowing down required by a condition like LS could actually be the blueprint for a deeper, more resilient form of intimacy that every couple could benefit from?
It is a powerful reframing. The condition strips away the generic default settings and forces you to intentionally build something custom and perhaps much stronger.
Exactly. It takes a terrifying, isolating diagnosis and transforms it into an opportunity to build a completely new foundation for connection. Thank you so much for joining us on this deep dive into the sources. We hope this arms you with the knowledge to keep exploring, to keep questioning, and to fiercely advocate for your own health and your relationships. Until next time.